Now we're starting, okay. Good morning, everyone. Welcome to Grand Rounds. This is our first Grand Rounds for Women in Medicine Month in September, and this will kick off our series today. We're going to have several announcements. I'm going to pass it to Dr. Ozdalga for it.
Thank you, Dr. Harmon. I first just wanted to thank Dr. Harmon and really a lot of our leadership. Dr. Dunn is here as well, Dr. Salas, Dr. Caceres, for really setting up an amazing Grand Round series this month. We're celebrating Women in Medicine Month. We're celebrating other things as well throughout the month, but we're kicking off Women in Medicine Month, this amazing picture that we do every single year. And we also, by the way, have as you know by now, Zoom backgrounds to celebrate everything, including Women in Medicine Month. So please do grab your Zoom backgrounds. I do want to now turn over to our division chief. Many of you have known Dr. Saul Rosenberg was a huge member of our division, our department, our community. Personally, he used to help me come teach the residents for many, many years. He was a wonderful clinician, a wonderful human being. And unfortunately, he passed away. We just learned recently. And we have Dr. Wakely, who has wanted to come and say a few words about him. So I'll turn it over to Dr. Wakely. And thank you, Dr. Wakely, for your leadership and many faculty in your division who's been helping us honor him well. So thank you for being here. I'll turn it over to you.
Great. Thanks, Errol. Really appreciate the opportunity to speak about Saul, who was truly the founder of our division. We sadly lost him earlier this week on September 5th. He had gotten to 95. We actually, as a division, had celebrated him earlier this month, or in August. He was a pioneer, particularly in lymphoma and Hodgkin's disease, but really in oncology overall. He truly founded the division here in the early 60s. He was recruited by Dr. Henry Kaplan, who was a radiation oncologist at a time when there really wasn't a field of medical oncology. And so he built the division into what it's become. He remained active up until his 90s. He was still seeing patients until just before the pandemic, and was continuing to teach until very shortly before his death. He was the Maureen Lyles D'Ambrogio Professor in the School of Medicine, Emeritus, at the time of his death. It's hard to really convey how much he and Dr. Kaplan were able to do in treating Hodgkin's. And this was really just the first part of his legacy, but the two of them worked together to combine chemotherapy and radiation, which really hadn't been done very much before that. And this led to the first real cures in Hodgkin's disease, which I think for most of us in the audience and today, Hodgkin's disease is a very, very curable illness, but it wasn't until the work that Saul and Henry did together. And then that's been, of course, built on and on and on. He was within our sort of national and international societies. The American Society of Clinical Oncology is one of the biggest in the world. And he was the president for that. In 1984, he was honored with the David Karnasky Award, which is the highest award, and also received a Distinguished Service Award in 1998. He has been sort of he was our founding father and a mentor to all of us. I wanted to read a few quotes from our really senior members of the division, and one of whom was Ron Levy. Ron, of course, was our second chief after Saul. And he stated that Saul really recognized the importance of medical oncology before it was a subspecialty, before people really saw the hope that we're now able to provide to oncology patients. As mentioned, he founded the division. He pioneered the idea of randomized trials in lymphoma and really helped to build that whole field of randomized trials in general, which is the foundation for most of our treatment options. He founded, as part of our division, we used to have Saturday conference, and this was every Saturday morning, still in practice when I was a fellow and into early parts of my career, which was a time when we came together. And for those of you who don't know, the oncology division really considers ourselves a family. It's got to be a really big one, but in the days when Saul had founded it, that was part of the principle of who we were, was that we would all work together, support each other, share cases together. And I think that's really critical, that concept, because it's tough work, and to be able to support each other was really and remains really important. I think Ron's actual quote too was that he taught us how to be better doctors and caregivers. He loved his patients. He will be missed by all who knew him, worked with him, were taught by him, and were treated by him. Ranjana Advani, another core member of our division who was a mentee of Saul's. Remember, Saul is a giant in the field of lymphoma who led pioneering studies in the diagnosis and management of Hodgkin and non-Hodgkin's lymphoma. Amazing mentor, humble, gentle, compassionate, and caring. He influenced many generations who can never fill his shoes, but who can walk on the path that he bravely paved for us. He inspired and generously supported many of us as his trainees, including Dr. Advani Ranjana, an honor which I will never forget. And the last quote, in 2018, he did an interview and was asked what was his legacy. And he said, there are three things I'm going to leave behind: my children, my students, and my patients. And then my advances in the treatment of lymphomas were tremendous, but they've already all been surpassed by the work of others who have built upon that. My students, whether it be medical students, postgrads, colleagues, were my greatest advance. I'm so proud that they've succeeded so much. I felt that I've been the trunk of a tree, and every branch that comes off carries twigs and flowers and plants that multiply. And what I've done just because I started them off. And I'll end with that. And we'll be doing more to honor Saul in the coming months. So thank you.
Thank you so much, Dr. Wakely. And it is just remarkable to hear and to have experienced this remarkable heritage with Dr. Rosenberg. And so our condolences and thoughts for everyone who he's touched and his loved ones. I'm going to take a moment to pause. And we'll be moving on to just some announcements for this month. You'll see on the slides our next inclusion rounds. Wanted to highlight is going to be in honor of National Disability Awareness Month. And this will be on October 3rd. We'll have a virtual panel at noon, and it will include Dr. Garner, Joseph Garner, who's a faculty member, Suchi Rastogi, who is a student, Meredith Becker, who's a staff member, and Kevin Mintz, who is a postdoc in our Bioethics Center, and it'll be moderated by Dr. Holly Tabor. So join us October 3rd at noon virtually for that. And lastly, just to talk about our upcoming speakers. So next week, we'll have Dr. Martha Gulati. She is the president-elect of the American Society for Preventive Oncology, and she will be speaking next week. The following week will be Dr. Monica Vela, who is an associate dean at the University of Chicago. On the 28th, we'll have Dr. Elena Rios. She will be here in person in this room. We'll definitely give reminders again. So she'll be visiting campus, and so that will be in person. She's the president of the National Hispanic Medical Association, so please join us. And with that, it is my great pleasure to introduce our speaker for this morning, who's here in person, Dr. Urmimala Sarkar. So Dr. Sarkar is professor of medicine at UCSF, just up north in the Division of General Internal Medicine, and she's the associate chair for faculty experience for the Department of Medicine, which is a very vast department, 36 divisions. Wrap your head around that. And she's the associate director for the UCSF Center for Vulnerable Populations, and a practicing primary care physician at Zuckerberg San Francisco General Hospital in their Richard H. Fine People's Clinic. Her work centers on innovating for health equity and improving the safety and quality of outpatient care for everyone, especially low-income and diverse populations. Her expertise spans topics including medical errors and patient safety, diabetes, cancer prevention, and survivorship. Her research is collaborative and intersects with methods found in human-centered design, human factors engineering, data science, health services research, and implementation science. She has received funding from the Agency for Healthcare Research and Quality, the National Cancer Institute, the Food and Drug Administration, the California Healthcare Foundation, the Commonwealth Fund, and the Gordon and Betty Moore Foundation for the design to implement and evaluate technology-enabled approaches to improve diabetes and other chronic medical conditions and patient safety. She's published over now 200 peer-reviewed articles and serves as an expert for multiple health policy and nonprofit organizations. And she believes in mentoring and training with a commitment to diversity and inclusion as critical to achieving health equity. And she does advance health equity scholarship by mentoring students, house staff, junior faculty at UCSF and beyond, and recently, just in 2021, won the 2021 SGIM Mid-Career Research Mentoring Award. And so it is my pleasure to welcome her back to Stanford. She completed her undergraduate degree here. So without further ado, Dr. Sarkar.
Truly always a pleasure to be back at Stanford. Thank you so much. Wonderful introduction. Okay, so as with all grand rounds, I need to start with disclosures and funding, and I'm delighted to take questions about any funding sources afterwards. Today, I would like to define digital health equity. I want to map the domains of digital health equity onto the socio. And I really hope that I leave you with some high priorities for intervention. So health equity and the digital divide, I'm going to touch on briefly. I have found gratifyingly that I don't need to spend as much time on this background as I used to. So go over that pretty quickly. I want to share a framework that my colleagues and I developed to think about digital health equity. And I'll leave you with some recommendations. A lot of opinions, and I'm hoping that we can have some time. Okay, so the first point I want to make is that digital is here in healthcare. And this may seem obvious standing here at Stanford, which is such a place of digital innovation. But for many years, digital was on the periphery of healthcare. And now it is no more, particularly during the pandemic. We had a forced and at times painful digital transition. And now, instead of saying digital health, we can just say health, and we're talking about digital. I'm also sharing with you the Robert Wood Johnson Foundation definition of health equity, which is the opportunity for everyone to live the healthiest life possible. And I'm sharing this graphic, which I'm sure that many of you have seen, but just to reinforce that when we're talking about equity, we're not talking about everybody getting the same thing. We're talking about everybody getting what they need to thrive, right? So what do we know about digital and marginalized populations? We know that patients have a high interest in digital, but there are barriers with devices, internet, and skills. We know that communities have existing but untapped capacity, particularly in public agencies, to support digital inclusion, and there's potential for our healthcare organizations to connect with those communities. Know that there are many digital health companies in the private sector focused on population level disruption, but they face challenges interfacing with the complex healthcare landscape. Know that programs are necessary to drive change, but we also know that policies are insufficient to drive behavior. Right? So my thesis today is that we need to work across these levels if we want to get to digital health. So there are some gaps and challenges, but there are also some opportunities. The fastest growing group of smartphone owners are those who are low income on Medicaid in this country. So there is digital access. On the other hand, there are data barriers and literacy barriers for patients. Community organizations and advocacy groups are very well positioned because they have trust with communities and patients. However, structural disinvestment, disenfranchisement, and structural racism have all undermined the abilities and capacity of communities to work. Know that in restructuring care, particularly during the pandemic, our health systems have done a lot for digital inclusion. We also know that there is a great deal of variation by site and in the level of implementation. Industry has a lot of advantages in this space, an important partner. And that's because there are resources and agility and a willingness to move quickly. There is a lack of an equity mandate when we think about how the private sector is doing digital. Finally, in terms of policy, there is now a newfound recognition that it needs to be a part of digital policy in this country, but we still have misaligned incentives and reimbursement. So this is how I think of where we are right now in general terms, and I'm going to give you some specifics. First, our framework. This is not the only framework, but we published this last year, and this is a way of looking at digital health equity through the lens of the socioecological framework. So just as I shared with you what I think of some of the gaps and opportunities are by level, this is thinking about what are all those drivers of digital inclusion across multiple levels of individual, family, home, community, services, including healthcare and policy. So I'll come back to the recommendations in this framework, but I'll try to give you some examples from our own work about each of these domains and how they relate to equity. Starting with digital interest, readiness, and literacy. As this is medical grand rounds, I do have to start with a case. Mr. J is a longtime patient at our clinic. He was a liver transplant 15 years ago at a tertiary care center. Still receives primary care at clinic that he has attended. Primary care physician notes that one of his immunosuppressive medicines that's on his list is not in his tote bag of medicines that he brings to every clinic. And Mr. J tells his doctor that he has not been to transplant clinic because they're doing everything on the computer now, and he doesn't know how to get refills. So does this resonate with anyone in the room or on the Zoom? We are decreasing more person-powered modes of access at the same time that we're increasing automated modes of access. And this just does not work for all of our patients. Many patients who are disproportionately chronically ill, who are disproportionately low income, have no home internet, lack of basic digital skills. So in this study, these statistics come from the city and county of San Francisco, but they're quite applicable more broadly, that 37% of our non-English speaking residents lack home internet and basic skills. It's 40% for those who are over 65, half of low income adults. These are the people who could most benefit from tools in their everyday life to support their health and healthcare. And these are the people who need support when we're thinking about new modes of care. So that mismatch is going to come up over and over again, and I want you to keep that in mind. Okay, so this was a study that was done actually pre-pandemic with a foundation grant among our low-income publicly cared for patients in the safety net in San Francisco. And the bullet here, the main take home, is that when we asked safety net patients if they were interested in video visits, they were. And they were able to successfully complete test visits. The most common barrier was internet and data access, and paying for that data to do a video visit was a big, significant barrier for people to take on virtual care. Okay. Sorry, just to go back to this, even pre-pandemic, in this very diverse low-income sample, there was high interest in remote care. And there are other studies in other settings ranging from the VA to more advantaged privately insured healthcare settings that demonstrate a uniformly high interest even pre-pandemic in remote care. So this is not different, but actually the point of the study is it's not different, right? Our most vulnerable patients really do want to use remote care. So moving forward, our remote tools well suited to people who need them. And this is another study that's looking at patient-facing tools. This was a study that we did of contact tracing apps. As you know, almost every state in this country put out a contact tracing mobile application or app that was intended to help people during the early days of the pandemic understand their risk for complications, understand what they needed to do, and perform public health contact tracing. What we found is there were 26 apps that we could look at, and we found that most were available only in English. Most had a high reading level. There is a consensus that the 6th grade reading level, which by the way is the reading level for text in the newspaper US News and World Report, that is considered to be the standard for readability in healthcare related education materials that are public facing. And what we found was that the majority, 69%, were above a 9th grade reading level, which is significantly higher than is appropriate for health materials. We found that many did not link to public health websites, which feels basic to me, or testing sites. So there was pretty limited functionality, and very few had inclusive illustrations. And I know that might sound like a minor issue, but it is really alienating when illustrations show only people who are white and are supposed to represent our entire diverse community. It does not make diverse communities trust the information that is contained in these applications. So the visual aspect should not be underestimated. Okay, so there are many things we can do that are not being currently done to make patient-facing digital technologies more equitable, including improve the literacy level, improve the representation in visuals, and making sure that they have the functionality that they can really make things more seamless and convenient for people, rather than having the experience that we've all had when we've you tried to use some digital tool of realizing, oh, I have 10 steps and this is only helping me do the first 3 of whatever task we're doing. Okay, so some methods that we can use to get to a better place: community-based participatory design, usability testing, centering universal design principles that are some of those I enumerated around literacy and inclusivity. And finally, academic and industry collaboration can enable iterative improvement. I've made a lot of tools using my NIH grants, and I have now a very clear understanding that we in academia, our skill set is not building beautiful tools that draw people in, right? But there are actually people trying to sell us things who know how to make beautiful, well-designed tools. And we need to take advantage of those skills in order to advance health and health equity. Okay. So this example is from my colleague Courtney Lyle's work, and I'm a supporting player in this. But the goal of this work was to develop and test personalized SMS text messaging to improve diabetes and depression management. And this is a collaboration between a depression psychologist and myself, a primary care physician, and an epidemiologist, health services researcher in this space. And the focus, and our psychologist colleague came to us and said, all of my patients who I see in depression group all have diabetes. Said, that is true. All of our diabetes patients are depressed. So we decided that we would try to work on those 2 things together. And what we did was we co-developed the intervention with our participants. We did open-ended interviews, and then we did card sorting. Can I just have a sense of people in the room who, Stanford is where card sorting was really pioneered. Do you know that method? Okay, so that I'm hearing some different feelings. So I'll just say what you do is you have cards with words on them. And there are words that represent things people value. So they could say freedom, they could say community, they could say love, they could say energy. right? Different ideas. And participants who are the target users of whatever tool you've developed sort the cards and pull out physically the cards that represent their values. And this is a design thinking method that was pioneered here and is very widely used. So we did that co-design, we did card sorting. And what we found is that while these co-development methods are very important, they actually don't necessarily perform in the same way for people with a limited educational attainment, for limited literacy, and with limited experience with these kinds of tasks that have a kind of quasi-academic feel to them. So we learned that asking people to articulate a lot of feedback about what they would want in the abstract was not as generative as if we had been doing the same task, say, with the people in this room or on this Zoom. And one of the underappreciated aspects about design thinking is that just as these methods can bring to light ideas and needs that we don't know, and that's why we need to start from a place of participation, these methods also need to be adapted to the populations in which we're using them. That was the point I wanted to make there. Okay, so thinking about the family and home domain, this is also a critical domain for digital equity. And the way that I think about this is that all of us in this room have helped a friend or family member who is having a challenge with a digital task, right? All of us have done that. And my mother-in-law likes to have my teenagers help her because she says they're more patient than her sons. So we all know, we've all been through this. So it's really important as we consider strategies for digital health equity to take those supports into account. And in a prior study, we asked adult caregivers for older adults, how would you want to use a patient portal? When we're implementing a patient portal, how should we do it? To this day in 2022, even though we've had an explosion in patient portals during the pandemic, there are still not clear and generalized standards for proxy access to patient portals. So this is still kind of the Wild West, even from a regulatory and accreditation standpoint. But what do caregivers want? Okay. We assessed the features. We showed people the patient portal. It is not pretty, right? And then we asked patients and caregivers, what would you want your caregiver to see? What is an important feature for you? And there were a lot of barriers. People were worried about security. There was a lack of digital literacy and a preference for in-person communication. We all know that it's gotten harder to get that in-person communication, and all of us miss it. But I think it's particularly fraught for some of our more digitally challenged patients. But there was a really high interest in portal use among caregivers to support their roles as interpreters of health information, to do care management, and to advocate for quality care. One of the best things about virtual visits, particularly for older adults, has been the ability for family members who live at a distance, who may not be able to attend an in-person visit, to attend a virtual visit. And I'm sure those of you who have done virtual visits with patients who are practicing clinicians have very much appreciated being able to have that family involvement. I see nods in the audience. Now, I just want to give you one thing to think about, which is that inbuilt virtual visits in electronic health records. For example, Epic has the ability to do virtual visits without using a platform like Zoom, which is what I think that you use here at Stanford. However, they cannot be three-way. So the health systems that disproportionately care for low-income patients also are strained and are not, for example, the San Francisco Health Network has a contract with Zoom that we are going to sunset because of cost. So we are going to be using a native platform, and that constrains our ability to do things like call in interpreters, call in family members. And this adds another layer of challenge to getting to digital equity. Okay, I'm going to keep moving. Actually, we are about halfway through, so let me pause and ask if there are any questions about the patient or family home levels before I keep moving. Yes.
Additional things.
Yes. So the question was, are there other ideas to engage patients besides just making something available to them? Things like gamification or creating community and using peer support to encourage healthy behaviors. The answer is there's really abundant evidence that those things work for digital health. So some things that have been done, including tobacco quitting interventions that are much more effective in online communities than they are in an individual context. Exercise interventions, a really interesting experiment was done with college students that showed that if you put them in groups and then you make the groups compete against each other to do more physical activity, that was more effective than putting them in groups and just telling them to encourage each other within the group. And both of those strategies were more effective than just giving them individualized or either tailored or standardized, hey, you should exercise advice. So this I think is where we can learn, right? People make games. There are many companies that we know of right down the road that are really skilled at getting people to engage, much more than they want to, actually. So can we take those strategies and use them for health? I think it's an excellent point. Okay, so thinking about communities. So we recently decided that one way that we could think about digital inclusion was to target an intervention at community advocacy groups. And we did in-depth interviews. We walked around the neighborhoods with our participants, and we did clinic visit observations. We created our original project was around mapping of community resources, and it was going to be participant targeted, really individual with chronic disease targeted. And then after doing these formative steps, we realized, that there are actually community assets, and making these organizations, these advocacy, these leadership groups within communities more easily available to tap into resources around them is probably more effective than targeting individuals. So we pivoted and really tried to make it easier for example, our local food pantry resources to pull something up around where's the closest drop-in mental health center. And it's been interesting. People have been testing this resource, which is mobile, and it's on a Salesforce platform. And we have found that even what we thought of as the most usable and easy for people who are doing things like working at a local food pantry or trying to keep people from getting evicted, we need to make it easier. We need to just make our digital tools work so seamlessly, because the capacity to do anything beyond what is right in front of them is really low. Okay, services. There are many things that we can do within healthcare systems for digital health equity, including digital training, technical assistance, and linguistically and culturally concordant staff. And where we fall down on this is not knowing what to do, but actually doing it. There is such a challenge with implementation and evaluation in real world settings. And I want to just embroider my slides for a minute and say that we are in a moment of incredible workforce pressure, right? We all recognize this in healthcare, but I want to underline for you that workforce pressure is a barrier to equity, right? We are bleeding people, right? Whether they're medical assistants or nurses or physicians, in all healthcare systems, because we were working at capacity before the pandemic, and then the pandemic happened. And when we face shortages, constrained access, it really affects our ability to provide equitable care. So I'm not going to I spend a lot of my day in my role as associate chair for the Department of Medicine. My domain is faculty experience. So I do spend a lot of my day thinking about the workforce. I'm not going to spend a lot of time in this presentation talking about that, but I would be remiss if I didn't remind all of you that part of an equity strategy is a workforce strategy. Often people in the workforce who are linguistically and culturally concordant are those who are at most risk of falling out of the workforce when societal pressures begin to mount. So that just decreases our ability to provide equitable care. Okay, keep moving. Okay, here's another case. There are no microphones or webcams on clinic computers. The first patient is Miss H, who is hearing impaired. The PCP is shouting at the top of their lungs onto the telephone. This is very disruptive to everyone else in the clinic who keeps walking down and peeking and trying to figure out what's going on. The patient assumes that their very kind doctor is just calling to check up on them and does not understand that this is a visit. The PCP talks to the patient with great difficulty, gets very late for their next visit, calls the pharmacy to refill the medications that the patient has lost. And the patient comes into the clinic the following day because they didn't understand, is not able to be seen, and is very upset. So this is the point where if the room were full, I would ask people to raise their hand if this had happened to them. There's only a few people in here, but let me just ask, has this happened to you? Okay, I do see a few hands. Thank you, Steve, for that. The second patient is a monolingual Cantonese speaker. Interpreter services says we're too busy to make outpatient calls. We're swamped. You have to call the patient and make sure they're there, and then you can call us in. So the PCP then calls this interpreter on the cell phone and puts it on speaker, and the patient on the office phone and puts it on speaker and has a three-way call. Now, I'm just going to tell you that this has happened to me many a time, and I do see other people nodding here. This is not how anybody wants to deliver care, right? So this is my example of what we need to still do to get to digital health equity. We did a study in the early days of the pandemic that was really an operational survey across different services at San Francisco General Hospital, which has many outpatient services, to understand safety net clinician experiences with telemedicine. And I want to tell you things have improved since then, but I actually, we continue to hear from people who are asking us, can we do this? Can we use your survey items because they're so relevant? So I'm thinking this is still an issue. Not having enough phones, having trouble scheduling, lack of video, lack of internet, right? And many FQHCs in this country also do not have good broadband access. And if we are delivering a significant amount of telemedicine, we're restricting access. Trouble using apps, speech, hearing, or cognitive barriers, communication quality, lack of privacy or confidentiality, diminished patient comfort or trust, and lack of knowledge or skills to participate in the video visit. Extremely common. The darker lines, and you don't need to know all of the bars on this graph, but the darker lines are for video, and you'll see that a higher proportion throughout are having challenges with video. So are there things that we can do about that? There are actually, and one of the great things that we can do when we think about doing implementation of new services in the safety net is to think about peer learning. And the Commonwealth Fund provided, and the California Healthcare Foundation provided funds for a telemedicine collaborative across the California safety net. And we worked on a small part of this around language access, and we developed a toolkit. So this toolkit had a bunch of different resources. It had scripts for medical assistants to call somebody up and say, hello, Mrs. X, you are going to have a telehealth visit in 15 minutes. Do you know how to get onto Zoom? Let me walk you through it. And they had these very, very scripted workflows. So there's a lot of granularity here. And from peer clinics who were able to get things going, there was a much better sense of you can't, the safety net, the places that disproportionately deliver care to the underserved are not necessarily able to translate lessons generated from Stanford Medicine or from UCSF Health, because the set of resources, conditions, and assets they're dealing with are completely different. So it's very important to create peer learning within similar work systems. Okay, so this is one thing that was in this toolkit, was digital screening. So FQHCs asked, what should we ask patients to understand if they're ready to do a visit? And some of them would be, do you have a device with a camera? Do you have Wi-Fi? These seem very obvious, but having a set of standard questions really helped staff in these types of clinics. And then this is from Alameda Health. I've kept their logo at the top of this. These are the instructions that they gave patients about how to get onto a video visit. So you'll see that the first step is get an email address, and that this is a 14-step instruction for patients to be able to get onto a video visit, because your starting point is you need an email address. I think over the course of my studies, I've probably my teams have probably created, I don't know, maybe 10,000 email addresses among all of it. It's a totally different starting point. So this type of technical support has to become part of operations and not kind of a reaction to a crisis. Okay, so let's think about policy. Broadband devices, accessibility standards, and reimbursement are all policy gaps that we have right now. We did a study of looking at an implementation study to try to understand how we could get patients in safety net hospitals access to virtual reality as a pain management modality. And I'm interested in that because it is a effective FDA-approved modality for chronic pain that does not have the morbidity associated with many medications. It is in use in many more advantaged healthcare settings and not in use that I'm aware of in any safety net settings. So we did a qualitative implementation study to try to understand the barriers. And while I could talk about this study very extensively, what I will tell you is that policy is a major barrier. And innovative modalities of care cannot be adopted, cannot be taken up unless there is a pathway to pay for these, right? This seems very obvious, but it is still something that many digital health companies and strategies are bumping up against. Is what is the reimbursement strategy? So value-based payment is promising because then you're looking towards outcomes and not towards what specific things are individually reimbursed. And there is a need to make Medicaid a more attractive payer. Right now, when I speak to digital health companies about the need for equity, they often look right back at me and say, we can't survive financially if we're looking for reimbursement from Medicaid. So rather than just leave those out there, I want to acknowledge that those are major challenges that we need to grapple with. And we need to ask ourselves, are we going to provide quality care in an equitable fashion? And if we want to do that, we do need to pay for it, right? Okay, I think I've already shared what's on this slide. These are some of our specific findings, but a lack of bandwidth and resources and lack of reimbursement are really come up over and over again. Okay, This quote is from a clinical research coordinator who was working on a VR study. We developed a community screener for community clinics to understand who would benefit from VR for chronic pain. Oh, it's exciting. Slides decided to run away without me. But no one was willing to buy tablets, even if there was outside of cost. How do you work around the cost? I guess it's insurance. Is there going to be a point where insurance can subsidize it, VR, as a treatment plan? Okay. Many of you are wondering, I know, what is the strategy to get people free and low-cost internet access? I've talked about access many times. And the answer is there are ways to do this, but they're more complicated than they need to be, right? As with many public assets that we have in this country, there's sort of a triage by hassle, right? So if you don't know how to get it, you don't know how to fill out the forms, you don't know what office to go to, then you're not going to find it, but it's there. So there is free and low-cost internet, there is Lifeline, and there are PCs for People, which is a nonprofit. Some people refer to Obama phones. I don't know if you've heard that before, but Obama enacted a program to get low-cost smartphones, which are on the Android platform, to low-income people. Those programs are still existing. They're a little hard to find. Okay. So going back through, I've given you a litany of different challenges and approaches. So I want to come back and highlight what the recommendations are. The first is to conduct design and evaluation in the right populations. And what does that mean to me? That means across levels of income, across levels of literacy, across levels of English proficiency, and across race and ethnicity. We need to think about doing the formative work in the populations that we hope will benefit, rather than developing something in advantaged populations and then assuming it will work in less advantaged populations. I'm going to strongly recommend implementation science methods to improve the quality and effectiveness of tools in context. And why do I feel like implementation science is an absolutely crucial tool to get to digital health equity? It is because inequities are context specific. And if all we look at is effectiveness devoid of context, we are not going to be able to understand how these tools are taken up in real life. And that entails not only measurement of use and measurement of your outcome of interest, but also qualitative methods of understanding the why behind when things are taken up and when they are not. We definitely need to develop appropriate incentives for industry to innovate around digital equity and for clinicians to share and recommend digital for their patients. It can't be a hassle for clinicians who are at the end of their rope. It has to be something that benefits patients without adding work for clinicians or without making clinical work more feasible in some way. And finally, there is a real need for capacity building within the healthcare digital ecosystem. Now, I think of Stanford as absolutely fundamental to the digital healthcare ecosystem. There are many digital health tools that have been spun out of Stanford. Many Stanford experts are intimately involved in developing digital health tools in the private sector. So what do I mean about building capacity for equity? I'll give you an example. The American Medical Association has an advisory board that is an innovation and equity advisory board. And they try to, among investors and entrepreneurs and digital health companies and insurers, try to share the importance of health equity and the paths to get there with this larger ecosystem. Similarly, when we think about the places where digital health comes together, like the Health Conference or Rock Health, it becomes critically important to put equity on the table in these fora. And I would submit that all of you who are experts in equity, there is a role for you to engage with the private sector. I always feel that if I am not at the table talking about equity, that no one will be, and that the needs of the patients that I take care of will be largely unrepresented. So I would encourage you as much as possible to think about public-private partnerships, not because we all want to go work in the private sector, but because we can be the people who bring the idea of equity to the table. Okay, I thank you very much for your time. I'm going to stop with a few minutes for questions. I look forward to the discussion.
Thank you so much, Dr. Sarkar. I will first turn to the room with regards to questions. And since I have a handheld, I can actually bring you the mic. Okay, I'm going to Dr. Salas here.
Hi, good morning. Thank you so much for sharing so much wonderful scholarship. It was amazing to see it all come together in this presentation. To your last point about partnering with private groups, it really resonated for me what you said about how we may not be able to make fancy looking or engaging tools, even though we have the knowledge, the academic knowledge of what needs to be conveyed to folks. And you're making this point about partnering with these organizations. Do you have any recommendations on how people can go about identifying a foothold in any, like, whatever company that they're thinking about partnering with? If they see something that they're like, oh, that would be great to partner with this thing we've been working on. How do people go about bridging that gap between where we sit here and what's happening not far away, but seems like a totally different world?
That is such a good question, and I wish I had a very straightforward answer. I send a lot of unsolicited emails, and I walk up to a lot of people and say, hey, you know, are you thinking about communities of color? Are you thinking about low-income folks? When I hear them, and I think showing up, right? So that's my short answer. Showing up at these more industry type events, whether there's something like, I did a seminar called, or a talk called, Are You Making Health Tech or Wealth Tech? At South by Southwest. That is not an academic conference. I don't think my promotion committee was very impressed, but it gave me an opportunity to talk to a different audience. So I think talking to as many different audiences as possible and not being afraid to reach out, well, it doesn't have a high hit rate, but that's what I have been doing.
Thank you. And one other question here from Dr. Ash.
Thank you. What a wonderful presentation. And here's how I know you're really good at reducing digital inequities. You taught an older faculty member how to use Twitter years ago. That happens to be myself. But I do have a question. And that is, it's very much a follow-on to the question that was just asked. If we're not good at making the bright, shiny tools here in academia, what are we good at? What is the thing that only academia can do? Is it point to the problem? Is it study implementation? What is it?
There are, I hope we can do a couple of things, but I'm gonna, when we have a public-private partnership initiative called Solve Health Tech, and when we are talking to digital health companies about what we can do, one is that we have a deep-seated, sometimes lived experience with diverse patient populations and their health needs. We have walked with our patients, sometimes with our family members, through healthcare systems and that don't always serve them best. So we have that. And for the most part, the private sector in digital health is not very diverse and does not have a lot of diverse perspectives. So we can offer that. We can offer our rigor, our academic rigor, and our lack of attachment to the success of any particular tool. So I think part of collaborating, and I think this is what you were getting at, Steve, is collaborating ethically, right? So when we work with digital health partners, we keep the data, we make a commitment to publishing it, regardless of whether or not tools are effective. And we do not allow our industry partners to influence our assessment of their efficacy, usability, adoption, implementation, any of it. So I think our skills are important in terms of being able to really truly understand from real world data if things work. But more important than that are our academic ethics and our commitment to building a generalizable body of knowledge.
Amen to that. We had one other question. I think we have time for coming from our virtual audience around portals. And one of the questions surrounding something you mentioned, that a lot of these patient portals, My Health, are only in English, and kind of curious around what the barriers are for not being able to adapt or to have those portals available in other languages, like Spanish, for example. Is it cost, technology?
There are some good portals that are available in multiple languages, and they tend to be products or platforms that people can buy in addition to the electronic health record. Moreover, Epic, which I mentioned before, is available in Spanish at Kaiser, for example. So there are strategies. Now, Kaiser has invested so much in customizing that and in making that portal availability in Spanish. Out of the box, Epic, which is what we use in the San Francisco Health Network, does not have that functionality. And ironically, safety net healthcare systems are often spending so much on their electronic health record that it constrains their ability to buy other tools. So it is partly cost. The other thing that happens with cost is it's not just the cost of the tool, it's the cost of the support and the ongoing technical support to run those things. So we have about a fifth of the staff per provider working on our Epic implementation and maintenance compared to UCSF Health, a fifth, so 20%. So our IT guys, our IT people are so stretched that integrating in another tool it just feels impossible.
Really points to some of the capacity workforce challenges as well. It is the top of the hour. Thank you so very much, Dr. Sarkar, for joining us, and we'll see you all next week in Grand Rounds. Thanks.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.